Some of this is nasal. I also have a lot more, so some of the slides that I'll show are going to be a little bit more detailed. I'll try and go through that and try and focus on what's important from the primary care perspective as to what you're looking for before referring on. Sarah's actually going to start this off with talking about what sort of things that we would sort of expect from a referral perspective. So I'll hand it over to Sarah.
Lovely, thank you. So I'm Sarah Charlesworth. I'm the lead nurse for the Sheffield Syncope and Cardiac Autonomic Service. So as Jonathan said, I'm just going to introduce a little bit about what we do and what we offer really. So our service is predominantly nurse-led, so we're seeing patients who are referred into the service for episodes of transient loss of consciousness and also cardiac autonomic causes, so things like query POTS. The service is split into two, and really that's to risk stratify patients so that we can see them in a timely manner if we need to. So we see 20 new syncope patients a week, and that's all done by the nurse specialists. For the cardiac autonomic, which I'll call CAN, we only see 3 new patients a week. And we are a regional centre for TLOC, so transient loss of consciousness, but we only see patients within Sheffield for the CAN patients. So a few years ago we had to shut the doors because we were inundated. So we are 3 nurse specialists and 1 cardiac physiologist, but it equates to just 2.5 whole-time equivalents, so it's not many of us really. And then we've got 2 consultant cardiologists, Dr. Sahu and Dr. West. And they do 1 clinic a week and they see 24 patients. So the aim obviously is to investigate the episodes of TLOC for any potential cardiac syncope, that's what we're looking for, and also manage the autonomic problems. Okay, so I was just going to talk a little bit about when to refer. So myself and my colleague Melanie Ferrer, we do all of the grading for the service, for both sides of the service. And in the referral, what we're looking for is sort of keywords that will help us triage the patients into whether they need to be urgent or routine. So obviously we're looking for any cardiac sounding red flags and any abnormal ECG findings. They'd automatically would triage them into the syncope urgent. The routine is anybody regionally who's passed out, who obviously in the absence of any red flags. And then with the routine CAN, so we don't really have an urgent CAN clinic as such. What we do with those patients, we ask really that they've had symptoms for longer than 6 months, and that all the causes have been ruled out. Also that the lifestyle measures have been adhered to, so often we find a lot of the dizzy, lightheaded patients, they might not be drinking enough or having enough salt and that type of thing, so we ask that before they get referred. And then BMI can be a big thing as well, so we wouldn't investigate them in the CAN clinic if the BMI was less than 18. If they were passing out, we would investigate them from a syncope point of view, but then to rule out a cardiac cause, but then we'd discharge them until they with a healthy BMI. So waiting time. So we've worked really hard over the past, I'd say 8 months to tackle the waiting times. We had really long waits post-COVID. And what we've done is we've reconfigured the clinics to triage the patients better with the staff that we had. So we've now, as you can see, we've got for an urgent syncope appointment, we wait 2 to 4 weeks for that. For a routine syncope, patients are waiting 6 to 8 weeks. Obviously, because we've seen the CAN patients as being less risk, they'll be waiting about 8 to 9 months. And as I put there, we're just triaging on the referral basis. So what I would say, sometimes we get patients in the CAN clinic who've waited 9 months because it's query POTS. But actually when they come through, they've been passing out. So had we known that, we would have put them through into the other one. So things like that, that's just what we're looking for really. So here I've just listed some of the red flags, which I think probably you've done already, haven't you? So we can move on from that one, I don't want to repeat. So here, this is just an audit that we did the other year about who we're actually seeing in the service and what's actually coming through. And as you can see, the reflex syncope and orthostatic hypotension is sort of our bread and butter really. That's who we're seeing the majority of. And then we've also got the drug-induced hypertension, so a lot of the elderly patients, polypharmacy related. And then 4% is cardiac syncope, so that's obviously what we're trying to find. And I just wanted to point out POTS is actually, we used to be called the Sheffield POTS Service, and we rebranded about 3 years ago to cardiac autonomic, because what we found is that actually there's a really low yield for POTS. It's very rare to diagnose it. What you find is that a lot of the patients who are presenting with dizziness, palpitations, they actually have orthostatic hypotension with a compensatory sinus tachycardia. And the other thing I was just going to say is the other thing on the rise is the non-epileptic seizure disorder. Not on the rise, but we're picking more and more of it up. So we do work quite closely with the neurologists. It's covered in yours. So here this really is just basic stuff, but it's just a lot of what we do, but also what we'd like to see done before the patients get referred, particularly with the orthostatic patients, so the patients who we think may have POTS. So we just that they're having adequate amounts of fluids, so 2.5-3 litres, and the right fluid. So we often get patients where they're having lots of caffeine, lots of energy drinks and tea, and they add that into the total. So yeah, just make sure that we make sure that they're drinking the right amount of stuff, and then that they're having enough salt. So we ask them all to have a teaspoon of salt unless contraindicated. And what we do a lot of is 24-hour urine collections for sodium, just to make sure that they are having enough salt. And then I've just added here, so this is, obviously it's predominantly a nurse-led service, so we're doing a lot of psychological support with them and sort of lots of lifestyle measures. So we refer them for orthotics, for compression tights. We get them to squeeze everything together, all the muscles together before they stand, and really try to empower them so that when they are having dizziness, lightheadedness, passing out, that they can manage it themselves, because we found that a lot of patients ended up going back to A&E before they got the results. Lots of patients are obviously understandably frightened by passing out, and it was just our way of dealing with that really. So we do provide a lot of psychological support for these people. A lot of the patients, the elderly with like postprandial hypotension, we just get them to have small meals little and often, and yeah, so the emphasis really of what we do is trying not to over-medicalise things and just really just try to give them the power back so that they can control this. And then, so yeah, that's it. Thank you very much. Thank you.
Right, so sorry about this. This is going to be a little bit more boring. So Sarah and her team actually do a lot in terms of, they actually see patients right at the start of all of this, and often once they've actually had their investigations done, then they actually come back through their specialist to actually get the support they actually require. So I'm going to come back to this case because there are some features on this, and we're going to go through some of the things that the emphasis of today's talk is going to be what you guys normally see, looking for certain red flag symptoms and signs before actually then sending those cases on to us. But so this is, I'll come back to this at the end, but a 57-year-old woman who was referred late last year, and she had a history of shortness of breath, lower extremity edema. She had 4 episodes of syncope without warning. She had some dizziness and postural change, and she has a history of some palpitations, and that's her background. So I will come back to that, so we can think about that in terms of some of the actual red flag symptoms and what actually happened to her. So this is the impact of syncope. So I think many of you will actually know this. This is actually pretty common. So between up to 50% will experience an episode of syncope, 1 to 6% of hospital admissions, 1 to 3% of emergency room visits. Over the age of 45, almost 20% of people present with syncope, and it can account for minor injuries about 30% and major injuries about 14%. So it is quite impactful. This is some data from Framingham, so don't worry, there's not really a lot of slides about lots of sort of studies and so on. So this was the Framingham study, so following people for many years. So this was data on almost 8,000 patients. The point behind this was, and this is one of the sort of key parts about the syncope service, is trying to pick up those patients who actually may be more at risk, the cardiac risk of dying suddenly. And you sort of see the red line here, the cardiac cause. The 6-month mortality in patients who actually have a cardiac reason for that is about 10%. So, it is important to try and pick up those patients, investigate them, and offer them the appropriate therapy. One of the other things that came from this particular amount of work is that over half of the patients who present, even though with a good history and examination and ECG, no cause was readily diagnosed at that point, so it required further investigations. So I'm going to cheat. I'm going to use the latest sort of guidelines. So our Cardiac Society, American Heart Association, also refers to the 2018 guidance. So there is a distinction between, so Sarah's mentioned TLOC, transient loss of consciousness. There is a distinction between syncope and TLOC. This is the diagnosis of syncope, transient global cerebral hyperperfusion, characterized by rapid onset, short duration, and spontaneous complete recovery. That is different from the diagnosis of TLOC, and you can sort of see a number of other features which comes into transient loss of consciousness. So typically the patients that we see through the syncope service are patients who, a lot of the other causes have actually been excluded, and we're seeing patients with syncope, with transient and fully reversible. So looking at this chart here, so